Good afternoon, everyone. I hope you can hear me. Thank you for the invitation and thanks for the challenging opportunity to defend the case for active surveillance for the case Isabel presented. I have no conflict of interest to disclose for this session. So let's go back to a summary of the case that was presented. I truly acknowledge the fact that there are some issues with the case and some discrepancies here, and a few of the parameters that should really trigger you to decide on how to proceed in this case. But let's not forget that the case also has some really favorable parameters. And I think that's the point I would really like to make. Are we looking for reasons to treat or reasons to initially defer treatment? Is the glass half full or half empty? So let's go back to the somewhat more classic data. In this time of MRI and very advanced technologies, we should not forget this important data. From SEER data, more than 30,000 patients with prostate cancer who were managed conservatively. If you zoom in, you see that these men with Gleason 7 prostate cancer, stage 1C, and this man is 65 years old, the risk of dying of other causes is still 10 times more than the risk of dying of prostate cancer. So let's not forget that. Some more data from Professor Hamdi, who will present in a minute, from the PROTECT study. Men were randomized between monitoring, surgery, or radiation. And if you zoom into this figure, you see that there's no difference in mortality. And the PROTECT study has been criticized for the fact that it's mainly low risk, but still there's about 1 in 4 of these men who have Gleason scores higher than 6. So also many patients with a Gleason score of 7, as was the case in Isabel. So another study, PIVOT, a randomization between surgery and observation. There was a small advantage for prostatectomy. And well, they tried to do a subgroup analysis, which of these patients had an advantage of surgery. And as you can see, our case, okay, he has some of the parameters in favor of surgery, but also many that are not in favor of surgery. Vickers did this analysis based on SPCG4 data, the study that randomized between surgery and watchful waiting in Scandinavia, and tried to estimate which individual patients had a benefit of surgery versus watchful waiting. As you can see, the most benefit is for these higher Gleason scores. And the Gleason score 7, okay, there is an advantage, but it is really diminishing at 65 years of age. And let's not forget that the life expectancy is different between these Scandinavian men and men in Germany. It's about a difference of 2 years. So this man, the advantage of surgery is really diminishing quite rapidly with these advancing years. So my first stay-home message is Gleason 3+4, that's not the man whom radical therapy is always beneficial for. Okay, next point. In the ERSPC study, of course, that wording, cribriform growth, is of course very important. I really acknowledge that. As you can see, the men without cribriform growth, the Gleason 7, had the same outcomes as Gleason 6, and the ones with cribriform growth did somewhat more poor. And if you ask experts in this detective consensus study, they also agree that cribriform growth should be a reason not to start active surveillance. But, well, this is like a new fashion to report cribriform growth. It's like spreading like some kind of airborne transmittable virus. The ISUP now recommended to report it. And in my center, it's almost all the cases have cribriform growth now. So please be aware that there's a large inter-observer agreement or disagreement in this case for staging cribriform growth by the pathologist, and also actually for the percent of pattern 4 that's present. So I understand that cribriform growth may scare you a bit, but does that really, is that really the case for your center? Some more data that the situation we're in now, staging people using MRI and not only systematic biopsies, but only systematic and targeted biopsies, really has an impact on the outcomes of these men. This is a paper by Guillaume Ploussard, and as you can see, for the low, intermediate, and high risk groups, the difference between targeted versus systematic only biopsies is really huge. There's some data from Professor Klotz, of course, on the outcomes of active surveillance men, and he reported that most of the men with metastasis had Gleason 3+4 at diagnosis. But remember, these men were diagnosed up to 1995, which is ages ago. So our current methods of staging and grading are really different. So my second stay-home message is Gleason 3+4, it's hardly comparable to the classic Gleason 7 anymore. And let's go back to the detective consensus project. If you ask the experts again, they agree that Gleason 3+4 should not be an automatic exclusion criterion. So my stay-home message 3 is Gleason 3+4, the experts agree that's whom active surveillance should be an option for. Last point, look at this data by Giorgio Giandaglia. He made a prediction model trying to find pathology stage 3 or high Gleason scores at prostatectomy. And as you can see, the PSA, clinical stage, biopsy Gleason, number of positive cores, and PSA density were all associated with unfavorable outcomes at prostatectomy. But our case, well, he has quite some of the favorable parameters, doesn't he? And let's not forget, he also had an MRI, and the MRI did not show any abnormalities. And it was also referred to this morning by Caroline Moore. The predictive value of a favorable MRI is quite huge. A non-visible lesion with Gleason 3+4 has the same outcomes as a Gleason 3+3 with a visible lesion. So this man has quite some of the favorable characteristics you need to start active surveillance. The application of a risk model is very important to expand the patients that are eligible for active surveillance. So please do not use these fixed criteria to deny a man for active surveillance. And if you see one, then he cannot start active surveillance. But please exploit all the data you have, including that MRI, to decide on whether a man is suitable for active surveillance or not, because that truly enlarges the group that suits active surveillance. So stay home message 4, my last message is 3+4 multivariable assessment will help decide who active surveillance is really for. So to conclude, I think initial active surveillance is unlikely to cause any harm in this case. I acknowledge there are some factors that should trigger you, but please check in your own center if that cribriform growth really has the predictive value it has in these studies from Rotterdam with expert pathologists. And well, my take-home messages are below. And if it rhymes, it must be true. So that's it. Thank you very much.